Hi, everyone. Welcome to Quality, where we're exploring quality in emergency care. Today is the next episode in our Stroke Initiative series as part of the Emergency Quality Network Stroke Initiative. I'm joined by Dr. Corey Zackerson, who is the co-lead of this work from MGH. And our special guest today is Dr. Puneet Gupta, who's an emergency physician at UCLA and also assistant medical director of the LA County Fire. Big EMS player, can tell us a lot about what's not only happening in the pre-hospital environment, but how that connects to our work in the ED. Welcome, Puneet.
Thank you so much for having me. I really appreciate the opportunity.
Yeah, I got to start by saying, a lot of the folks who listen to Quality are medical directors, they're quality directors, they're frontline clinicians. And we have this tendency in emergency medicine, probably true in all of healthcare, to live in our silo. And so we think of stroke care as when that stroke alert goes off on the overhead or the charge nurse tells us there's a new stroke alert patient, to whether or not we're getting them to timely treatment. And we sort of probably forget about and ignore that whole pre-hospital world. What do you think is happening in that pre-hospital world that we should be not only aware of, but is making a big difference for patients?
God, there's so many things in the stroke world that's happening in the pre-hospital world that I think that the listeners should be aware of. Number one, I think the number one biggest topic right now is comprehensive stroke centers or stroke centers that are capable of intervention. And the biggest question is if you're in a city where you have the choice to go to a regular ER that maybe has a neurologist versus an ER that has an interventional neurologist or IR capable of retrieving clots available, where do you take that patient and how do we filter the patients best towards whichever ER that would best serve them? And so in that regards, number one, just so everyone knows, we're constantly working on refining our algorithm right now. And there's a couple of them. There's like LAMS and Cincinnati score. But we have these algorithms already designed to kind of help the EMS filter the patient towards the ER to best serve them. The reason we do this is because we don't want to overwhelm the comprehensive stroke centers, but we also want to make sure that the large vessel occlusions go to the right stroke center. That's one of those things that we just kind of have out there just to make sure that you're not a doc in a shop without an interventional radiologist sitting on a patient with an LVO.
I got to think that, in general, when you say it, right patient, right care, right setting, we say this a lot. We make this phrase a lot in emergency medicine, and everybody agrees with it at the top line level. When we talk about this one, it's not just getting the right stroke patient to the right place. It's about getting the right critically ill patient to the right place. It's about even within our hospital, did we admit the patient to the right service? But it's always hard to do. And there's, different reasons. Sometimes you have patient preferences around which hospital they go to. My guess is that there's always business considerations, that one hospital doesn't want to lose patients to another hospital, or they're afraid of what that might mean. You're in a huge county, probably one of the biggest county healthcare delivery systems in the country. What are some of those tensions you've seen? Like, has there been pushback around this idea, or is it like, how do you navigate that?
What's funny is it's actually been a driver for hospitals from the EMS standpoint, because strokes, to put it bluntly, a stroke patient is good money. And they want the stroke patients, they want the STEMI patients. And so not only has it driven hospitals to increase their specialist availability, but we also, by indicating that if they don't meet certain compliance measures, we may potentially take away these specialty rights for them, has allowed us to drive the hospital administration to improve their metrics for us, if that makes sense.
Yeah, we've been dealing with this in Massachusetts. They actually passed legislation last year for with like bypass protocols and the regulations are not yet out. The DPH is writing them still. They were supposed to be out in the spring, and everybody's anxiously awaiting. So it's fascinating. I'm totally with you, and this is the thing that everybody is talking about. I think we've seen what you're expressing also, that the non-comprehensive centers are really worried that these bypass protocols are going to end up taking patients, sort of shunting patients away from them and towards the comprehensive centers. And like the people in the comprehensive centers are also worried, like, we don't have capacity to absorb extra patients if we're doing all of this bypassing. Do you have insight into how well the sorting is happening in the pre-hospital setting? Like, how well are we identifying those patients who should go to the comprehensive center versus who don't need to? Are the scales performing well? Like, are you guys getting feedback on that?
We actually do have the data, at least in LA County. LA County has been extremely aggressive about figuring out how well our sorting is going. And so I'll get you that data right away. But the long and short of it is it's not perfect. We definitely miss some LVOs, but the vast majority of intervention patients are going to comprehensive stroke centers.
That's really interesting. And I think, the fact that you guys are pulling this off in LA, yes, I'm sure it's more resource, but it's also a really complicated place for healthcare. You got a lot of hospitals, a lot of healthcare systems, you got a lot of traffic, you got all the problems. And so I have to think that, solving this equation is probably hopefully easier in a lot of other geographies where you may only have one place with thrombectomy available, maybe only a couple places, transport times are less. And so it hopefully is cleaner in a lot of other spots.
It is definitely cleaner than a lot of other spots. But what's interesting, and I used to work in the middle of Michigan, and I worked in a lot of other settings, is that the thing about working in the ER, and you guys know this, if you work in any size city, you usually have that one hospital that's got everything, and that one hospital that's got nothing. And so the medics know which way to go in terms of that. So sometimes it makes it simpler, and then sometimes you only have one hospital to go to, so it doesn't matter anyways.
What's been, we recently launched at our shop about 2 months ago, our first real initiative around door to CT. And it has been, we're showing improvements in our door to imaging times. But it seems like it's really challenging in the sense that we haven't had this kind of a collaborative intervention where it requires changing ED workflows and changing the workflows of EMS agencies, sort of in some ways, wildly different way. It doesn't mimic something else that we do. We don't have any other direct EMS to other things that are time sensitive. We certainly can have, an EMS team bring in a patient that's laboring and we quickly decide, okay, can they go up to labor and delivery? But we're not trying to reduce something from 16 minutes to 10 minutes when we do that. We have some direct to cath lab protocols for STEMIs, but STEMIs are really infrequent. We see in our big system where we care for half the care in the state, a couple STEMIs a day versus we probably have 15 to 20 stroke codes a day. And so what's your experience been with these door to CT protocols? Are you guys implementing them out there and how are they going?
We are implementing them. And personally, and I might be biased because we have a really strong neurology program, they work great. They do work great. I think the biggest, I wouldn't say the biggest barrier, but the biggest implementation hindrance, I guess, if you're looking for cutting down the time, as an interesting point, is trust. How much does your hospital trust your pre-hospital team? And that could be justified or not justified. But if there is a lack of trust in the clinical skills of the pre-hospital team, then that will significantly delay this door to CT time, even with these expedited protocols. And for the medical directors out there that are trying to work on this faster, one thing that we have noticed that has significantly improved this trust, if you will, was just actually working on it. So I granted I get to get a different window into the world because I'm both sides. But when we noticed one hospital was not having as smooth door to CT times, we've tried to figure out why, and we realized that, long story short, during COVID, gotta blame it on COVID. During COVID, the paramedics turned over because all the paramedics that had been there before had gotten tired, they burnt out, and they promoted out of being a paramedic. And so we had these brand new paramedics who are told that this hospital is full of just people who don't like them. And so they're really bitter. The nurses are pissed off, so they're really bitter. And so you have the nurses don't like the medics don't like the nurses. Eventually nobody's talking to each other, and eventually nobody trusts each other. And so we actually had to make a concerted effort for the nurses and the paramedics to actually get to know each other. And just through that interaction, we're improving in the trust. We had to drastically improve just like understanding, and that actually improved the door to CT time.
How did you guys do that? Like, what did it look like to create strategies to like increase interaction and improve trust?
We had well, first of all, I had to go high enough where someone actually cared. Uh, so the funny part, the thing about the fire department is that and this is the ER. I'm going to give an ER to fire department analogy. Is you have your regular firefighters and paramedics, and you have your captains. These are the ones that oversee the stations. Now, the captains of the stations are very much like the charge nurses of your ER. Super mother Henley. They protect the heck out of their people, and they're gonna fight for their people to the death. And that's really great unless you need to look at a bigger picture. And so you have to go to the next level, which is the battalion chief. And I had to grab some nurse supervisors, and I had to be like, look at this problem. I sat them all down in the room, made them look at the problem. They're like, this is a big problem. And then what we basically did is we made the kids play together. It was kind of like prom, uh, junior high school prom. We made them dance. We made paramedics sit with the nurses, and then we made the nurses ride out with the paramedics, and we got them to know each other again.
That's interesting. In some ways, we've experienced this tremendous turnover in that frontline healthcare workforce, and it's happened, everywhere, right? It's happened in the pre-hospital world. It certainly happened in the emergency department world, and so I think we probably took a lot of relationships for granted that had developed when we had much more stable workforce in the prior couple of decades, and we've had sort of this wholesale flip in the last few years. And I love your junior prom analogy, because we sort of do need to reintroduce everybody. And those relationships that probably greased a lot of throughput, got patients in ED, built that trust that you're talking about. We need to rebuild it now. But I think, I don't think it's actually that hard, because we're definitely all in it together. We feel the same pressures and same pain. It's just new folks, but they're all eager, right? They're all choosing to come work in the ED as a new nurse, or they're all choosing to be a new paramedic. And so they just need to have the chance, I think, to build those relationships that sort of had previously existed. Puneet, this is great. We've been talking a lot about EMS, probably in our minds, thinking about the folks that are bringing patients in, because working in the ED, that's the people we meet. But the reality is, for most patients out there, if they've got stroke symptoms, it starts with a phone call to 911. And that's a dispatcher, that's medical command. It's all these other things in pre-hospital care who we never meet in person in the emergency department. How does that play into stroke care and how we should be designing stroke systems?
I love that you asked that question, because it plays into so much of what we're doing right now. This is a hot topic, especially with AI. So there was a Germany study that found that if we took dispatchers and we trained them to learn for keywords that would indicate someone's having a stroke, the most sensitive one being, I think I'm having a stroke. So ironically enough, and taught them about these buzzwords and had them key it in their dispatch as possibly a stroke, the paramedics that went out to the field were more likely and had a higher sensitivity to diagnose that stroke. And when they had a higher sensitivity to recognize that a stroke was happening and they brought it to the ER had a higher sensitivity of recognizing that a stroke was happening faster at the charge nurse level. And thus, you basically have this anchor bias that starts from dispatch and goes all the way to the ER. And as you guys all know, quicker recognition of a stroke means quicker recognition of initiation of the system. In fact, in recognition of this, we have a couple of AI pro companies right now that are trying to develop this voice recognition of certain words to trigger pop-up to go up on a dispatch screen to say, hey, you might be having a stroke, patient.
That's so cool. So we improve the phone call detection with dispatch. We improve the EMS recognition and the EMS routing. And then we get the stroke patient and we're thinking about these door to CT protocols. Can you tell us, have you had experience with any of your EDs that you work with implementing a door to CT protocol and how that's gone, or any tips, tricks, pearls from that experience?
I can tell I definitely have, but just as a boot ER doc, the first time you're like, what's happening, right? Like, the first time it happens, everyone's like, we're going to CT. But I think like as doctors got more and more comfortable with it. At least in my ER, we've just gotten faster and faster at it. And nowadays what we do is the ambulance bay is open. I'm already waiting for that patient. The neurologist is walking down from wherever they've gotten their cup of coffee, and, and they're actually going down to the CT scan with the patient and getting that TPA ordered as needed, or TNK rather. I still call it TPA. Uh, there was obviously a lot of work involved with it, a lot of education, a lot of change management theory. We had a few PDSA cycles, but I feel like that might be the norm. What do you guys think?
Yeah, you know, actually, as you were saying this, and especially as Corey, as you sort of summarized that, the more I thought about it, particularly from a quality measurement lens, was, you know, there was an NQF, National Quality Forum Committee, some years ago around developing quality measures for regionalized emergency care. And I remember somebody sort of raised the idea of being like, you know, we often just measure what happens in the hospital. We don't think about the patient's whole journey. But we're starting to get to a place where we've got these AI tools and all these digital health applications collecting data, where we could actually start measuring how timely people get treated from the second they call 911, right? Or from the time that they really have first symptoms. And you can start tracking this as a community. And in the same way that we sort of know that there's wide variability in cardiac arrest survival rates when you go community to community across the US, and that's really triggered tremendous change in how we think about and care for cardiac arrest in the pre-hospital environment and the hospital environment. I see almost us moving in that same sort of model for stroke care. Puneet, thank you for joining us today. This was a great discussion. I learned a lot. I think I particularly appreciate two things you said. One is that we're going to have to learn how to build that trust between pre-hospital colleagues and those of us in the emergency department. And I really learned about how many different interventions and opportunities there are in terms of how we organize pre-hospital care for stroke patients and the care they get in ED. So thanks for joining us. Hope to have you back on, and we'll see everyone else at the next episode.